Okay, guys, let me introduce you to a living legend. His name is Dr. Barry Marshall, and he's a practicing doctor in Australia. And why am I calling him a legend is because he drank a solution containing Helicobacter pylori. Can you beat that? He drank a broth containing Helicobacter pylori, was sick for days altogether, and then he developed gastritis. And talk about dedication. Because prior to that, the concept was that nothing can survive in the harsh environment of the stomach. But this doctor took it on himself to prove to the medical world that Helicobacter pylori has that uncanny, nasty capability to survive in the harsh acidic environment of the stomach. How it does that, I'll be teaching you over the course of this discussion. But as I said, that is super dedication to medical field. And during the course of this video, we'll talk about the presentation and complications of peptic ulcer disease. Then we'll also talk about type A and type B gastritis. Helicobacter pylori is said to be causing type B gastritis, and at this moment what I can request you to remember is also the fact that type B gastritis begins with alphabet B. So remember that it involves the bottom of the stomach, and when I say bottom of the stomach, that would basically mean antrum. So that is why like type B gastritis caused by H. pylori is called as an antral predominant gastritis. Type A gastritis is autoimmune, and at the moment I can say that alphabet A is on the top and B is at the bottom. So at the top is the fundus. So type A gastritis, that is autoimmune gastritis, will mainly be involving the fundus, whereas type B gastritis, which is caused by Helicobacter pylori, is mainly an antral predominant gastritis. And then as a bonus topic subsequently, I'll talk about pre-malignant conditions of the intestine also, ranging from familial adenomatous polyposis to Peutz-Jeghers syndrome. The most common cause of peptic ulcer disease is, as I explained, is this nasty bacteria. His name is Helicobacter pylori, and it's responsible for causing type B gastritis. And studies have shown that this bacteria is not only capable of causing peptic ulcer disease, but has been called by WHO as a type A carcinogen. It's called as a type A carcinogen because it has been documented to cause a development of a tumor, and the name of the tumor is what you have read in pathology also, that is mucosal associated lymphoid tumor, maltoma. So maltoma is like a non-Hodgkin's lymphoma of the stomach, and again a peculiarity which has been asked in the exam with respect to maltoma is that which tumor can show a complete remission on antibiotic administration. He did not say the word H. pylori, he said which tumor. He did not even say stomach, he said which tumor can show a regression or a remission on antibiotic administration. Then the answer is the topic of interest, that is mucosa associated lymphoid tumor, maltoma, and this would be a non-Hodgkin's lymphoma of the B cells involving the stomach. In fact, I'm calling it a type A carcinogen because studies have shown that this can cause a gastric ulcer, and gastric ulcer is a pre-malignant condition of the stomach, and this pre-malignant condition then predisposes to development of adenocarcinoma. So indirectly, because H. pylori is causing gastric ulcer and gastric ulcer is a pre-malignant condition, so I can say that type A carcinogen once again, because by direct effect, there's a direct association between H. pylori and development of stomach cancer, which is bound to cause a development of pyloric stenosis and can result in then chronic vomiting or vomiting of previous day food items. We'll also talk about examination finding like succussion splash that can be present in these patients. But at the moment, the data is H. pylori can cause PUD, it can cause maltoma, it can cause a gastric adenocarcinoma. And in earlier times, like the diagnosis of this condition used to be made by doing a stomach biopsy, and that biopsy used to be then stained with a special stain, that is Warthin starry stain. But you can very well understand, you can see that black pack, that's the, I would say, multiple bacilli present extracellularly in the stomach mucosa. But nowadays, like we don't go for an invasive test like a stomach biopsy, we can diagnose it on non-invasive test, and the non-invasive test, which has a very good accuracy for diagnosis of this condition, is called as UBT, that is called as a urea breath test. Now there's a second test also available, that is by the name of stool antigen. We can do a stool ELISA and we can do a stool antigen also, but then lots of time that studies may not be, or like that test may not be properly validated. So he says that between the two, both of them have a good amount of accuracy, but then considering that a stool antigen test will need proper laboratory validation, the proper laboratory accreditation, a better test for answer would be a urea breath test. And in fact, this UBT is also used for determination of eradication of infection. I'm showing a table here. The table from the textbook mentions that urea breath test is not only useful for diagnosis, but here you can see that we have given first line treatment for the patient. After giving treatment, we wait for 1 month so that there is no antibiotics at the moment being given or PP or bismuth compounds. I mean, all the treatment is over, and after the completion of the treatment, we do a urea breath test for eradication of infection also. So at the moment for this particular slide, for UBT, I can say it's answer to 2 MCQs: best test for detection, best test for eradication of this infection. Now, this happens to be like a gram-negative spiral-shaped bacteria, and this produces the enzyme by which it can survive in the harsh environment of the stomach. The name of that is urease. And what does urease do is it produces ammonia. Ammonia is alkaline in nature, and therefore, because of the alkaline nature, it will neutralize the acid. So I can say this bacteria will create a micro-environment around itself. The bacteria will create a microenvironment around itself by which it is able to resist that harsh acidic environment of the stomach, and it is non-sporing in character, and it can transform into a cocoid shape. Normally, like we have either a bacilli shape or a cocoid shape, but this bacteria can transform from bacilli to cocoid and cocoid back to bacilli. That gives us uncanny capability to survive long duration. And because of the fact that it is written to be non-sporing, I mean, what is the important of studying the word non-sporing is that eradication is possible now. Suppose it was sporing, then even if you kill it, the spores will germinate. But now if it is non-sporing bacteria, therefore eradication is possible. So I'll talk about antibiotics. That's like clarithromycin and amoxicillin used for it. I mean, the usual mnemonic for that, I'll say here only, that is CAP, cap. P is for PPI, and then is clarithromycin and amoxicillin. And usually, like, we are giving this triple therapy for management of this patient. So the more details of the triple therapy will be added subsequently. Then as far as the route of spread of Helicobacter pylori is concerned, the methodology of spread would be fecal, which tells us that peptic ulcer disease is more common in developing countries as compared to developed countries. Initially, the impression was that this disease is more common in developed countries, considering that people would be like having a more comfortable lifestyle, so they are more stressed out, because if the more rich you are, then you're more worried about how the money is going to come, whether my bank account will, whether my money is growing better in FD or in stocks. I mean, that was the initial thought process. Rich people will get PUD, but then studies have shown vice versa. The incidence of PUD is more in relatively poor people or people with basic lack of sanitation. Then this is an extracellular bacteria. The importance of knowing that is that in the later part of the discussion, we'll talk about an intracellular bacteria, that is Trophairma whippleyi, which causes malabsorption syndrome. It causes Whipple's disease, but this is an extracellular bacteria that would be colonizing the antrum and the corpus. And as I explained to you, I mean, Helicobacter pylori is said to be causing a type B gastritis, that is at the bottom, and bottom would be where the antrum would be present. It is a microaerophilic bacteria because stomach will be having little bit of oxygen only. So considering that the rest of the colon is purely anaerobic, this is where little bit of oxygen is available. So therefore it is a microaerophilic bacteria. They love to mix up the questions with microbiology. So a couple of these options that I've said are having a replication from what you've studied with respect to microbiology on this topic. Now, because it's a urease producing bacteria, it will break down urea to generate ammonia, and this ammonia is alkaline in nature, and this alkaline pH will then cause irritation of the G cells, causing hypergastrinemia, stimulation of the parietal cells causing hyperchlorhydria, and that's the key word. If you get a hypergastrinemia as well as a hyperchlorhydria, then this extra acid will then flow into the duodenum and will mainly cause a duodenal ulcer, though it can cause a gastric ulcer also. But on a comparison basis, though the bacteria is sitting in the stomach, but it predisposes to development of duodenal ulcer. Now, why is that so? Is because you see, stomach has its own protection also, like it produces mucus, bicarbonate, prostaglandins. So stomach has its own protection system, and thereby prevents the acid from causing damage to the stomach mucosa. But duodenum does not have any such inbuilt protection. There is no prostaglandins, no mucus, no bicarbonate. Bicarbonate will come little bit from that Krebs or Leiberkuhn. That Krebs or Leiberkuhn, they'll be producing bicarbonate. But otherwise, that total mucus-based production or prostaglandin-based production is not available in the duodenum. So the chances of development of erosion in the duodenum and duodenal ulcer is higher as compared to gastric ulcer. The minimum thing to be remembered at the moment is stomach has its own protection system, duodenum does not. So the incidence of gastric ulcer would be lesser as compared to that of a duodenal ulcer. Then he'll also ask you regarding virulence factors, apart from obviously urease and flagella, because urease is allowing it to survive in that harsh acidic environment by creating that micro environment that neutralizes the stomach acid, because ammonia is alkaline, as I said immediately. Then flagella helps it to move across the thick gastric mucus. Then is CAG-A and VAC-A. The CAG-A is associated with inflammation and VAC-A is associated with damage to the gastric epithelial cells, though it's like extracellular bacteria, but still has the capability via the cytotoxin that it produces, two of them, a cytotoxic associated gene A, and then vacuolating cytotoxin A are the two virulence factors which helps in explaining the capability of damage that this organism can cause, and the amount of damage in the stomach and in the duodenal mucosa it can cause. Now we'll focus on the workup of this condition. Then we have non-invasive tests and invasive tests. Though the accuracy of both of them is same, but if the question says what is the best test for diagnosis, like earlier I was just saying that urea breath test is overall like used as a non-invasive test, but even if in the options invasive tests are given, even then the answer would be given as urea breath test. Then second is obviously stool antigen test. The hierarchies level I have already told to you that if both are given, then that's the order in which to be answered. For stool antigen test as well as urea breath test, he always gives this basic precondition that the test is to be done always 4 weeks after the stoppage of antibiotics. Like we give CAP, clarithromycin, amoxicillin, and then we wait for 4 weeks, and after that the test would be done. And we also should be stopping PPI 7 days before a urea breath test. So these are like preset conditions that must be met before the testing is done. And now let me mention regarding an invasive test, which I am like not saying that it is a useless test. Both urea breath test and urease test have a 95% or higher accuracy. But then nowadays is the era of non-invasive, so that should be given a priority over this urease, because urease test per se will be requiring a stomach scraping. You see, urease is present inside the stomach environment, no? So it's an invasive test. So you will have to like take a scraping from the stomach. So that would be done with respect to endoscopy. So first patient has to give consent for endoscopy, and then subsequently the scraping of the stomach would be done. And an alternative name for urease test is also called as flow test. So though both of them are like good ones, urease and stomach biopsy, but then on a comparison basis, if all are given, UBT, stool antigen, urease and stomach biopsy, if he just says what is the best test for diagnosis of H. pylori, best for eradication, answer is UBT. Already explained to you. We can do a urease test. We do urease test also. In all cases, ultimately we do an endoscopy. So we just have to take a scraping from there, and then subsequently the urease test can demonstrate, that can increase our diagnostic yield. So both UBT and urease can be false negative due to intake of PPI. That is why like we were stopping PPI, we were stopping antibiotics and bismuth. So that's with respect to like the test should not be done when the person is already on medication. Wait for 1 month after the completion of medication to demonstrate that okay, whatever we are yielding is like a true positive. I'll repeat my statement. Best for detection and best for eradication of Helicobacter pylori should be answered as UBT. But if I change the question and I say what is the best test for documenting peptic ulcer disease, then answer is not urea breath test. That is why the data was repeated, because the question in the paper said, I think this was FMG exam, the question said what is best to document peptic ulcer disease, and this is obviously not urea breath test. You will have to do upper G endoscopy to tell the localization of the tumor, and most of the time like it's gonna be the duodenal cap or the lesser curvature. Gastric ulcer is more common in the lesser curvature of the stomach, and duodenal ulcer is more common in the duodenal cap or the first part of the duodenum. Now, as far as the treatment of Helicobacter pylori is concerned, we always follow a triple therapy. So that is CAP, clarithromycin, amoxicillin, and PPI. The 2 antibiotics are given for 2 weeks and PPI is given for 6 weeks. The ulcer healing time, that is, ulcer healing time is approximately 6 weeks. And sometimes, I will subsequently discuss a condition in which ulcers may heal partially or may not heal, or even if they heal partially, they'll come back once the PPI is stopped. That is for a condition by the name of Zollinger-Ellison syndrome that has been discussed separately. But I'm just giving you a heads up right now that every time you read a question on refractory peptic ulcers or ulcers that tend to come back, that's one to be seen in Zollinger-Ellison. Then we also have a quadruple therapy. In quadruple therapy, PPI is the same. That's obviously understandable, but along with this, we are adding a surface protective agent, that is bismuth. Bismuth can cause a black staining of the tongue. So therefore, whenever it has to be given. It should be poured at the back of the tongue. Ask the patient to raise the mouth, and then the solution has to be poured at the back of the tongue so that he can swallow it fast. And what it does is, like, it will form a coating over the surface of the ulcer. The base of the ulcer is raw, and when acid comes in contact with that raw base of ulcer, it causes pain. So this is like a surface protective agent. It will form a coating, and because of this surface protective effect, it is able to reduce the acid mucosa contact time. I said that the base of the ulcer is raw, so when acid will come in contact with it, it will cause pain. If you reduce the acid mucosa contact time by forming a layer over wherever the ulcer is present, then there would be palliation of the symptoms of the patient. Now, the two antibiotics, clarithromycin and amoxicillin, have already been mentioned. So instead of naming about them, I can mention two more, that is tetracycline and metronidazole. Or instead of metronidazole, we can swap for ornidazole as well. So you'll see a lot of kids that might actually be having ornidazole, because metronidazole causes a bit of abdominal pain and has to be taken 3 times per day. Whereas, like, if I swap it for ornidazole, it might be taken less number of times per day. So depending on the compliance part, there are multiple permutation combinations available. But in quadruple therapy, it is PPI, bismuth, and 2 antibiotics. And the reason I swapped the antibiotics is because the 2 on the top have already been discussed. So I thought I'll introduce one more, tetracycline metronidazole. At this junction, I want to say that a question in the exam said, which antibiotic is not useful for eradication of H. pylori? And the answer is erythromycin. Like, clarithromycin will work, amoxicillin, tetracycline, metronidazole, but erythromycin has been found to be not effective for eradication. Then, because you are giving so many antibiotics, some people are not able to handle so many antibiotics and they may develop a diarrhea. So what we do is, in the first week, we give only a single antibiotic. And then subsequently, we upgrade to 3 antibiotics, that is amoxicillin, clarithromycin, and nitazoxanide. So you can see, like, because some people have less tolerance to handle multiple antibiotics, we initially go easy on the stomach and then go full on. This is an alternative approach, which is called as hybrid therapy, and then is load. Load means we are using levofloxacin. Then is going to be nitazoxanide, the brand name for that is Alinea, and doxycycline. So now you know more antibiotics, that is even levofloxacin has been added, doxycycline and nitazoxanide have been added, apart from the previous antibiotics that I spoke about. That was clarithromycin, then was amoxicillin, then I added tetracycline, and apart from tetracycline, I added metronidazole. So like 1, 2, 3, 4, and then 3 more, 7 antibiotics, but not erythromycin is used for management of this nasty organism. The topic was type B gastritis. Now I'll compare with type A gastritis. This I've done in other video lectures also, so the data is already on the slide. It's autoimmune etiology. The main antibody present here is called as anti-intrinsic factor antibody, because the parietal cells of the stomach are the ones which are getting damaged, and therefore there would be achlorhydria seen in this condition. Now, in spite of achlorhydria, there's going to be an ulcer. So mostly the query of most people is that, boss, understood that you are saying that a bacteria is causing type B gastritis and type A is autoimmune etiology, it's causing achlorhydria. If acid is going to be less, then how ulceration will occur? Well, the rationale is, I understand acid is less, so ulceration should not happen, but autoimmunity will damage the stomach mucosa directly. And if direct damage to stomach mucosa is there, it can result in development of ulcer. So the point is, I agree that acid is less, but still you'll notice that whenever gastric ulcer is occurring, in some varieties of gastric ulcer, which is like you can see total of 4 varieties, you will notice that in majority of them, the values of acid can be normal or it can be low also, or like in only one variety it is turning out to be on the higher side. No, that is type 3 gastric ulcer. But otherwise, in majority of varieties, either the value of gastric acid level is normal to low. If he says what is the most common type of gastric ulcer, then answer would be given as type 1, that is on the lesser curvature. And let me just rephrase the points of type A gastritis. It is, I'll write it and then erase it, but you can just practice with me because it's already on the slide, so I'll erase it. It's autoimmune. Then the antibodies which are present here are called as anti-intrinsic factor and anti-parietal cell antibodies. Over and above this will mainly be involving, this is going to contribute to achlorhydria, that is less acid production. And since in this person, the intrinsic factor is deficient, so therefore there would be anemia also. The type of anemia that is present here is also written as macrocytic anemia, also called as pernicious anemia. So a couple of A's, like what I have just made to you remember. And I also said that the location where this would be involved, because type A is right on the top, alphabet A is on the top. So it's the top of the stomach, that is the fundus that would be involved in this patient. But ulcer is not commonly in the fundus. The ulcer would mainly be present across the lesser curvature. That is type 1 gastric ulcer, which is a pre-malignant condition. Now, as far as gastric ulcer is concerned, it is more common with people having blood group A. That's just an association you need to remember. Whereas duodenal ulcer is more common with blood group O. So you can remember DO for that. DO is for duodenal ulcer for blood group O. Gastric ulcer is like very old people would be having it. Pre-malignant lesion, as I said, is on the lesser curvature. In duodenal ulcer, it is mainly the first part of the duodenum, and the size of the ulcer would usually be like less than 1 centimeter. Giant duodenal ulcers is when the size is more than 2 centimeter, and usually the cause of giant duodenal ulcer is not H. pylori, then it is Zollinger-Ellison syndrome. So like earlier I gave you a hint, Zollinger-Ellison syndrome will be having a refractory ulcer, but in this case I'm adding information, it would be a refractory ulcer to PPI plus giant duodenal ulcer. Now, why do patients of gastric ulcer, duodenal ulcer come to us? That would be like a deep-seated, as if somebody is eating from within, epigastric pain and epigastric tenderness. And some patients can be having tachycardia and orthostatic hypotension. One of the reasons for this can be that gastritis can contribute to multiple episodes of vomiting. So they can be like hypotension explained by that, or there could be a possibility of a GI bleed. I mean, it's not necessary that the person will always vomit blood. In case of duodenal bleeding, it might be just a blood that is bleeding into the lumen of the gut from the first part of the duodenum, and therefore these patients might be having melena for days altogether, followed by hematochezia. And that is why in my discussion earlier for the previous video of lower GI bleeding and upper GI bleeding, I said a duodenal ulcer is actually upper GI bleeding but can cause manifestation of hematochezia with hypotension. I reiterate my statement that duodenal ulcer is located proximal to the ligament arterite, so it's classified as a source of upper GI bleed, but the manifestations that would be occurring in the patient can be hematochezia due to extensive bleeding with hypotension. Then there can also be a perforation peritonitis. They love to ask about it. Rigidity of the anterabdominal wall is because of perforation. He might not write the word like, he'll write like this: perforation of the viscus that is responsible for the rigidity of the anterabdominal wall, and rebound tenderness would come. And succussion splash, the reason for that is gastric outlet obstruction. There are two reasons for gastric outlet obstruction. One is duodenal ulcer. If it's going to be present, it can cause the spasm of the proximal part of the stomach, that is of the pylorus, or another reason can be like the narrowing or the fibrosis that can be associated with healing of the peptic ulcer also. So GOO can explain the succussion splash, and sometimes gastric ulcer can actually contribute to a complete obstruction of the pylorus because of the tumor. And imagine if the pylorus is totally obstructed, then whatever the person has eaten, that will remain in the stomach only. So when you shake the patient, like patient is lying on the bed, you shake the patient, it would be like as if there is like water being shaken inside a container. Like if you take a ghada is that mitti ka bartan containing water, you shake water in it, you can hear the shaking of the water. I mean the sound produced by movement of water. Or you just take a bottle of water, partially filled, shake it vigorously, it will produce that sound of shaking water. Similarly here the stomach is filled with liquid, whatever the person is consumed. So when you shake the bed of the patient, you can feel as if there is like water moving around and liquid contents moving around in the stomach of the patient. That's what we call as a succussion splash. Now you can see here endoscopic view of a duodenal ulcer, in fact 2 of them, or a gastric ulcer, and then they're bound to be complications. The most common complication of peptic ulcer would be bleeding, and here he will ask you the source, because every time they ask you bleeding, they'll ask you the source obviously, and that would be the left gastric artery for a gastric ulcer. And if it's gonna be the duodenal ulcer, it's gastroduodenal artery. At this junction, I also want to remind you that duodenal ulcers can be involving the anterior part of the first part of the duodenum, or even the posterior part of the wall of the duodenum, and on a comparison basis, the bleeding chances are more with the posterior duodenal ulcer. The reason being that the artery is posteriorly situated. Anterior duodenal ulcers will mainly have a chances of perforation, and a posterior duodenal ulcer will be having a higher chances of development of a bleed. And if this bleed will occur, it can be life-threatening, it can cause severe hypotension. And I've described this in the earlier video, the previous video for this one, for GI bleeding, where I've told that if the guy starts bleeding, then what we need to do is we need to maybe put hemostatic plugs or hemostatic clips. So to take care of that bleeding artery, initially we'll inject adrenaline. Once the bleeding will reduce to an ooze, then subsequently hemostatic clips can be used, and then thermal coagulation can be used to control the bleeding. I mean, especially if it's a bleeding visible vessel, that's a source of nasty hypotension that can occur. And the endoscopic classification that is used to assess the bleeding risk is called as Forrest classification. The name of this has already been discussed in the previous video also, but just reiterating the statement, Forrest classification is based on endoscopic image. The endoscopy can be showing a healed ulcer, it can be showing a partially healed ulcer, it can be showing an ulcer which is showing exposed blood vessel that is bleeding and spurting blood on the camera. I mean, I said multiple things. One is a healed ulcer. Second is like an ulcer which is having a visible visible vessel at the base, which is literally spurting blood. So, aggressive endoscopic therapy would be required in such a condition, and the chances of mortality with this condition can be up to 10%. We'll do a volume resuscitation. There is no role of octreotide here. Octreotide is only for bleeding varices, so there is no role of octreotide here. We'll give IV fluids and we'll do endoscopic therapy for management of this patient. If he says, why would this patient die? Then majority of patients will die because of non-bleeding causes. That can be multi-organ dysfunction. Definition of multi-organ dysfunction is more than one organ malfunction that is occurring, and this could be like bleeding is causing first kidneys to fail. When the perfusion of the body will reduce, then the kidneys will begin to fail, and along with that, the loss of blood can also cause a cerebral infarction. So multi-organ dysfunction and pulmonary complications, that is aspiration, like he's puking blood and he might aspirate that blood, that can result in development or death in these patients. So most of the time it's like non-bleeding causes. Bleeding we can manage well. No, we can give blood transfusion, we can give fluids, or we can if I don't have any one of them, I can even give fluids to save the life of the patient. The main treatment is obviously fluids followed by blood transfusion. But the point is, because we can treat the hypotension due to bleed very well, so most of these patients die because of non-bleeding complications that could be ranging from multi-organ dysfunction to pulmonary complications. Then we can have a perforation, and perforation, the leading cause of viscous perforation is a duodenal ulcer. The mortality rate in this condition can be as much as 20%. So if he says, what is the most common complication? It is bleeding. But he says, which will have higher chances of death? Then it is a perforation, where there's a triad. The triad would be severe acute abdomen with tachycardia, and there would be rigidity of the anterior abdominal wall. Even if you remember the whole thing, rigidity of the anterior wall is more than sufficient. When you check out this X-ray, you can see the gas under the diaphragm. The radiological finding that we see here is called as cupola sign, or instead of cupola sign, he may use the word mustache sign. But I'll just keep it simple at the moment. The radiology people will make it sound like cupola. Okay, let me just write it down. The radiology people will say the word cupola, and then another one would be mustache sign. There is a reverse mustache sign also. That reverse mustache sign is what we see with heart failure. But today I'm talking about cupola and mustache sign, which are alternative fancy terminologies to describe gas under diaphragm for this patient who's having pneumoperitoneum. Now, a corresponding X-ray, you can see air just below the heart, and this X-ray is for pneumomediastinum. So two, I would say, X-rays which are like hot favorite of our examiner and is a part of every exam in India. One is pneumomediastinum and now second one is pneumoperitoneum. That should be remembered. I'll mention the names once again. Pneumothorax, that is discussed in the respi section. Pneumoperitoneum and pneumomediastinum are like hot favorites of our examiner. Now, there's another complication that can occur, which is penetration. Penetration is like very slow. Perforation is like explosive. Perforation is gonna be like a sudden damage, and penetration is like a slow, gradual erosion. So, like duodenal ulcer, it can burrow slowly posteriorly towards the pancreas. It can cause a development of necrotizing pancreatitis. It can cause a pseudo-pancreatic cyst that you read in surgery, and then gastric ulcer can erode into the left lobe of the liver. So, it is like penetration means a slow, degenerative process. Duodenal ulcer, it will go posteriorly and it can result in damage to the pancreas. Most of the time, either hemorrhagic pancreatitis, necrotizing pancreatitis, and even a pseudopancreatic cyst, and gastric ulcer for a left lobe of the liver erosion. Then is gastric outlet obstruction. Now, this is because of this is like most of the time seen in patients with duodenal ulcer. You see a duodenal ulcer wherever, like it's in the first part, no? So because of the pain, the proximal part will exhibit a spasm. Because of the pain, the proximal part will be showing a spasm, and that is gastric outlet obstruction, will be ulcer-related inflammation, local edema in the pre-pyloric area or due to duodenal ulcers, and can occur due to scar formation as well. Whenever there's fibrosis, they can be, once you've treated the patient also, they can be GOO, gastric outlet obstruction. The highlight of gastric outlet obstruction will be chronic vomiting. And because of chronic vomiting, you will notice that all questions that come on gastric outlet obstruction by default will always be incorporating this electrolyte aspect, hypochloremic, because there is vomiting, so there's loss of hydrochloric acid, and there would be a hypokalemic metabolic alkalosis. Now, the explanation for why it is hypokalemic metabolic alkalosis I've discussed in the electrolyte section in the kidney, but I can just put it simply: if the person will vomit again and again, the loss of vomit acid from the body will contribute to metabolic alkalosis. Hypokalemia is the only thing that are not explained here. For that, you'll have to refer to the endocrine section. But then hypochloremic, understandable, loss of hydrochloric acid, loss of hydrogen, so metabolic alkalosis, loss of chloride, so hypokalemic metabolic alkalosis, and then can be a gastrocolic fistula, which can be having a mortality of as much as 20%. So these are going to be like the complications that can be seen with peptic ulcer disease. And we have to use PPIs, but then there are bound to be side effects of PPI also. We'll now focus on side effects of proton pump inhibitors. The mnemonic for this is ABCDM, and the one that is very commonly asked is acute interstitial nephritis. This acute interstitial nephritis will say patient was started on PPI and subsequently starts having fever with a rash, and there is a rising serum creatinine in this person because there's a renal shutdown. This is a triad that is present for acute interstitial nephritis. The second name for the same condition is allergic interstitial nephritis, and one of the urine microscope examinations that we'll be getting in this patient would be eosinophiluria. Even in the blood, eosinophilia would be present. So this is one of the very common complications of PPI that can be asked. Otherwise, even with vancomycin, even the antibiotics, allergic interstitial nephritis has been demonstrated. Then can be bone pain. Then there is increased incidence of Clostridium difficile infection or increased incidence of community acquired pneumonia. Well, the explanation offered is only one, that when you give PPI, you suppress acid production in the GI, and when you suppress acid production, then harmful organisms can grow in the stomach and in the upper part of the GI tract, and therefore they can be aspirated via the saliva, microaspiration saliva, that can result in like an increased incidence of pneumonia in these patients. In fact, it has also been documented to cause CKD, which can be a sequelae of acute interstitial nephritis. And the rationale here is that PPI is going to act like a hapten, so it's recognized by the antigen presenting cells in the kidney as a foreign, and therefore the immune system starts turning against itself, and you have an inflammatory infiltrate in the interstitial space that can cause damage to the tubules. It can cause malfunction of the kidney, contributing to acute kidney injury. And the reason why like there is a hypomagnesemia is because of the impaired gut absorption. So this is a mnemonic to remember the side effects of PPA. Special interest here would be three of them, that is acute interstitial nephritis, increased incidence of pseudomembranous colitis, and increased incidence of community acquired pneumonia are like three important side effects of PPI to be remembered. Next, we'll focus on something that you remember from surgery as well, but I need to teach you this pre-malignant conditions of the gut. And I am having a patient who's having consumption of this betel nut / pan masala. You see lots of time these surrogate ads, even famous actors are doing advertisement of these pan masala and gutka. The problem is that betel nut is an erosive product. When it is going to be kept in the buccal mucosa, it can contribute to development of oral submucosal fibrosis, and the physical appearance of the submucosal fibrosis can be same as that of leukoplakia. So how would you differentiate is you'll ask the patient to open his mouth. In oral submucosal fibrosis, there would be difficulty in opening mouth, but you would not have any difficulty in opening mouth with respect to leukoplakia. Both will be white in color. Another important lesion that is to be remembered is oral submucosal fibrosis. Apart from erythroplakia, syphilitic glossitis, oral lichen planus can also be contributing to, or it is also pre-malignant, but the chances is least. This was again a question that came in the paper, like which of the following has least chances of turning from pre-malignant to malignant. The answer is oral lichen planus. Now, if you look at these images, you see initially casually they may look the same, but if I zoom in, you will notice that in this case, you can notice that zigzag appearance that is present. This zigzag appearance is what you read in dermatology also as Wickham striae. So what I want you to remember is that if they give you a white lesion in the oral cavity, then three possibilities are to be kept: leukoplakia, submucosal fibrosis, and oral lichen planus. In oral submucosal fibrosis, you can't even open the mouth. I mean the person's mouth, because submucosal fibrosis, difficulty in opening mouth. Here you can open the mouth, but you can notice this crisscross striations that are present. These crisscross striations basically tell you that this person is having Wickham striae of oral lichen planus. In contrast, if you look at the lesion in the first image, you can notice a white lesion. This is leukoplakia. So the differences between the three have to be remembered. And next, what I'll focus upon is pre-malignant lesions related to the esophagus. There are four of them: tylosis palmaris. If you read the name, there is like hyperkeratosis of the palms and soles. And what is the epithelium in the palms and soles? Stratified squamous. So there is increased risk of squamous cell carcinoma. I'll repeat that again. The epithelium in our palms and soles is very thick. It is stratified squamous. So it's squamous cell carcinoma risk that is increased. Then can be HLSD cardia or Barrett's esophagus. Barrett's is what you read in your pathology classes also. It increases the risk of development of adenocarcinoma adenocarcinoma, and then is post-cricoid dysphagia. This post-cricoid dysphagia is a term alternative one for Plummer-Vinson syndrome, and this is responsible for dysphagia in this person also. Why? Because there would be an upper esophageal web. I mean, that web is going to contribute to difficulty in swallowing, so that's why the word is post-cricoid, because patient would complain of food sticking in the upper part. If patient says food sticks behind the chest bone, that is like cardia, but food sticking in the upper part of the esophagus, that is a post-cricoid dysphagia of Plummer-Vinson syndrome. And then the features that are seen in this condition would be like iron deficiency anemia, coileonychia. Coileonychia would mean like there would be a spoon-shaped concavity in the nails. Like we read clubbing, no, clubbing is where we get a convexity. Here it's like a spoon-shaped concavity in the nails, along with presence plus minus of glossitis. So those are like 4 pre-malignant lesions of the esophagus in contrast to 5 that I told you for the oral cavity. And now we will focus on like pre-malignant lesions, like when we go lower down, like this is Barrett's esophageal and esophageal web. I mean, Barrett's esophagus can be picked up because in the esophagus, the mucosa is not supposed to be red like it is. You know, the stomach part mucosa is going to be reddish, but this tongue-like projections of red mucosa into the esophagus is like an endoscopic image of Barrett's esophagus. And any way to confirm it, we will have to do a biopsy. Then for the pre-malignant condition of the stomach, there are 3 of them. Type A gastritis, which is directly related to gastric ulcer, and therefore both have been incriminated as cause of chances of malignancy. And then is Menetrius disease. The highlight of Menetrius disease is that look at the giant stomach rugosities. Look at these folds in the stomach, and this is what is called as cerebelliform, because this looks like appearance of the brain mucosa, so it's called as cerebelliform appearance of the stomach mucosa. The highlight of Menetrius disease is that there is a foveolar cell hyperplasia and a parietal cell atrophy. Foveolar cells are in the stomach and they are responsible for producing mucus. Parietal cells are the ones which produce intrinsic factors. So in this condition, what you're getting is parietal cells are atrophied, but the foveolar cell hyperplasia is present, and hiding between this foveolar cell hyperplasia is a gastric ulcer. So indirectly, if you look at it, all the 3 conditions are ultimately, both the 1 and 3 are leading to point number 2. You know, I could have simply said gastric ulcer is a pre-malignant condition, move on. But then what, like an examiner would, he can ask you the causes for gastric ulcer. That could be type A gastritis or Menetrius disease, because parietal cell atrophy and less acid is also a risk factor. More acid is a risk factor for damage to the stomach, understandable. Less acid is also a risk factor, and therefore gastric ulcer contributes to pre-malignant status. Plus, there can be loss of proteins across this cerebelliform appearance of stomach mucosa. This is also an example of protein-losing enteropathy. The topic of protein-losing enteropathy is discussed subsequently in malabsorption syndrome, but I can give you a heads up. This condition will be having diarrhea with pedal edema. Intestinal condition which is causing a pedal edema. Normally you read about pedal edema with you read about pedal edema with like liver disease, or you read about pedal edema with kidney disease. But if you're having a diarrhea with pedal edema and hypoalbuminemia, the most important thing is the reason for the pedal edema part would be hypoalbuminemia. That's again a very good pickup point in a question. Diarrhea with pedal edema is an alternative term for protein losing enteropathy. The tests that are done for diagnosis of this condition, I'll focus on them in the malabsorption syndrome part, where I've discussed if you want to listen to it after this video, then if you scroll to the malabsorption, the last part of it, that's where protein losing enteropathy has been discussed. Because traditionally we read about hypoalbuminemia with like liver disease or kidney disease, but here a GI condition is contributing to this manifestation. Then is the endoscopic view of that huge and large rugosities of the stomach that's seen in Menetrius disease. And yep, one more thing, the treatment for this condition, guys, is not a gastrectomy, because the impression that will come from a surgeon's class would be he'll talk about various types of gastrectomy, but for Menetrius disease, it's not a gastrectomy, because removing stomach is not a solution, right? So we use a monoclonal antibody, that is rituximab, for these patients. Then a pre-malignant lesion of the small intestine is Crohn's disease, because Crohn's can involve whole of the GI tract, small intestine as well as large intestine. Then in the large intestine, it is one ulcerative colitis predominantly, and second is familial adenomatous polyposis. The gene for this is APC and chromosome number 5, and you get more than 100 polyps in the colon. If he says what is to be done in this condition, usually by the 30th birthday of this patient, we'll do a prophylactic colectomy. And patient is saying, are you serious? You're going to remove my colon. I tell him, sir, if we don't agree to this, even you will develop adenocarcinoma of the colon, just like your father did and died. His father has died because of colonic cancer. And on his 30th birthday, by the 30th birthday, we're saying we remove your colon, because even his colon is having almost like more than 100 polyps. That's the diagnostic criteria. Any one of them can then turn malignant. Then is Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is an autosomal dominant condition. The gene involved here is STK11, also called as LKB1 gene. STK stands for serine threonine kinase. And he can ask you like which chromosome is the one which is involved here. Your answer would be chromosome number 19, because I know that STK11 is what you're already familiar with. So I wrote it in the data initially, but then the chromosome part is also to be remembered. There would be two things here. One is mucosal melanosis. So there would be like black spots on the lips of the patient. And second, there could be development of hamartomatous polyps. Now, polyps are supposed to have predominantly epithelium and connective tissue, but here connective tissue is more. And that connective tissue which is more would be like, if I look at this image, you can see these strands of connective tissue which are running all through, like, appearance in a leaf. So that is why the pathologist will call this, these strands are connected tissue running through it as like arborizing pattern. So that statement has to be remembered from the pathology domain, that arborizing pattern is seen with respect to polyps in Peutz-Jeghers syndrome. There's a lot of smooth muscle hyperplasia, and this condition has a peculiarity that it does not cause cancer of the polyps of the small bowel, but it causes cancer of the hepatobiliary area, ovary, and cervix. So the cancer risk here that's the peculiarity that he wants to listen, that the cancer is not originating in the jejunum. It's mainly originating in tissues like ovary, cervix, and hepatobiliary areas. Towards the end, I'll focus on another peculiar disorder that's called as Cronkite-Kanada syndrome. This is usually seen, name is Cronkite-Kanada, but it's more common in Japanese population. Again, this will be having hamartomatous polyps, but these hamartomatous polyps are found all through the gut. Earlier, I was saying predominantly in the small intestine, but now I'm saying they're found everywhere except the esophagus. And additional findings in these patients can be like alopecia, onchodystrophy, diarrhea, and this would be having relatively a low risk of malignant transformation. So towards the end, I've talked about two disorders, that is both Peutz-Jeghers and Cronkite-Kanada having hamartomatous polyps. And because it is hamartomatous, because there's more connective tissue and less epithelium, you see epithelium causes more surface area and increases the chances of cancer formation. If it's gonna be like less epithelium and more connective tissue, then the chances of risk of malignant transformation is relatively lesser. Let's now focus on a couple of questions here. Like he says, patient has been diagnosed with Peutz-Jeghers, and what is the common sites of polyps? So piece of cake for you. I mean, the site here is small intestine, but your answer is jejunum. Then he says, what's the commonest source of bleeding in a case of duodenal ulcer? Your answer would be given as gastroduodenal artery. So this was, I think, a pretty straightforward topic, except for the few microbiological details that I made you remember. I think that most of the stuff is like, you read about the complications of peptic ulcer in surgery, you read about H. pylori in microbiology. So and a lot of details of type A and type A gastritis and pathology as well. So would have been like a quick revision for you for all these subjects. So keep on learning, guys, and keep on learning all the facts. Here you're having all of them at a single place. So I mean, this is like a cherry on the top on the baseline information that you've created. Thank you for your patience and hearing me out.